Differential diagnosis of Axenfeld Reiger syndrome. Molecular genetic studies may ultimately make the differentiation among the following phenotypic entities less relevant. The following items are nonetheless useful for phenotypic classification of these disorders. First is iridocorneal endothelial syndrome, ICE syndrome. The iris and anterior chamber angle abnormalities in the spectrum of disease resemble those of Axenfeld Reiger syndrome clinically and histopathologically. This led some investigators to suggest that the two syndromes are parts of a common spectrum of disorders. However, clinical features that distinguish the ICE syndrome from the Axenfeld Reiger syndrome include corneal endothelial abnormalities, unilaterality, absence of family history, and onset in young adulthood. Both conditions are characterized histopathologically by a membrane over the angle and iris, which is associated with many of the alterations in each disorder. Although the membrane in the Axenfeld Reiger syndrome represents a primordial remnant, that of the ICE syndrome results from proliferation of the abnormal corneal endothelium. Second differential diagnosis of Axenfeld Reiger syndrome is posterior polymorphous corneal dystrophy. One variation of this developmental disorder of the corneal endothelium has changes of the iris and anterior chamber angle similar to those of the Axenfeld Reiger syndrome. However, differentiation can be made on the basis of the typical corneal endothelial abnormality. Third differential diagnosis of Axenfeld Reiger syndrome is Peters anomaly. The spectrum of disorders that constitutes Peters anomaly involves the central portion of the cornea, the iris, and the lens. Similar changes have been reported in association with the peripheral defects of the Axenfeld Reiger syndrome, and the two conditions were once included in a single category of developmental disorders. However, this association is rare, and the mechanisms for the two groups of disorders are distinctly different. Nonetheless, families with known mutation in the FOXC7 gene have been reported with Axenfeld Reiger syndrome in most members but Peters anomaly in others. The fourth differential diagnosis of Axenfeld Reiger syndrome is aniridia. The rudimentary iris and anterior chamber abnormalities with associated glaucoma in this developmental disorder, that is discussed later, may lead to confusion with the Axenfeld Reiger syndrome in some cases. Mutations in the PEAT-X2 gene may manifest with a wide variation in anterior segment anomalies, including those phenotypically similar to aniridia. The fifth differential diagnosis of Axenfeld Reiger syndrome is iridogoniodysogenesis, congenital hyperplasia of the iris. Patients may have congenital hyperplasia of the iris without the anterior chamber angle defects of the Axenfeld Reiger syndrome. Autosomal dominant iridogoniodysogenesis anomaly type 1 in bracket gene map locus 6p26 bracket complete is caused by mutations in the FOXC7 gene and is characterized by iris hypoplasia, goniodysogenesis, and juvenile glaucoma. A distinct form of this condition also includes non-ocular features and is referred to as iridogoniodysogenesis syndrome or iridogoniodygenesis type 2. It maps to 4q25, is caused by mutations in the gene PTX2 in bracket OMIM 601631, 137600 bracket complete, and may be allelic with Axenfeld Reiger syndrome. The sixth differential diagnosis of Axenfeld Reiger syndrome is oculodentodigital dysplasia. The dental anomalies in oculodentodigital dysplasia are similar to those seen in the Axenfeld Reiger syndrome. These patients occasionally have mild stromal hypoplasia of the iris, anterior chamber angle defects, microphthalmia, and glaucoma. This condition is caused by mutation in the connexin 43 gene in bracket GJA1, gene map locus 6q21 Q23.2, OMIM 164200 bracket complete. Seventh differential diagnosis of Axenfeld Reiger syndrome is ectopia lentis at pupillae. Ectopia lentis at pupillae is an autosomal recessive condition characterized by bilateral displacement of the lens and pupil, with the two typically displaced in opposite directions. The correctopia in this disorder may resemble that of the Axenfeld Reiger syndrome, but the absence of anterior chamber angle defects is a differentiating feature. The eighth differential diagnosis of Axenfeld Reiger syndrome is congenital ectropion UV. Congenital ectropion UV is a rare non-progressive anomaly characterized by the presence of pigment epithelium on the stroma of the iris. It may be an isolated finding or appear in association with systemic anomalies including neurofibromatosis, facial hemiatrophy, and the Prader-Willi syndrome. Glaucoma is present in a high percentage of cases, and the ectropion uvea may be confused with that found in some patients with the Axenfeld Reiger syndrome. The ninth differential diagnosis of Axenfeld Reiger syndrome is congenital microchoria and myopia. The condition of congenital microchoria and myopia, characterized by bilateral small pupils and myopia, results from an underdevelopment of the dilated pupillae muscles of the iris. Transmitted as an autosomal dominant trait, this disorder has been associated with goniodysgenesis and glaucoma. Congenital microchoria has been linked to gene map locus 13q31-q32 in bracket entrace gene symbol MCOR, OMIM 156600 bracket complete. Patients with the Axenfeld Reiger syndrome may have a wide variety of associated ocular and systemic developmental abnormalities, and it has not yet been established in many of these cases whether the patient has a variation of the Axenfeld Reiger syndrome or whether the findings should be considered a separate entity. Management of Axenfeld Reiger syndrome. The primary concern about the management of ocular defects in a patient with the Axenfeld Reiger syndrome is detection and control of the associated glaucoma. IOP elevation most often develops between childhood and early adulthood, but it may appear in infancy or, in rare cases, not until late adulthood. Patients with the Axenfeld Reiger syndrome must be followed to detect glaucoma throughout their lives. With the exception of infantile cases, medical therapy should usually be initiated before surgical intervention is recommended. Drugs that reduce aqueous production, such as beta adrenergic blockers, carbonic anhydrase inhibitors, and alpha-2 adrenergic agonists, are most likely to be beneficial. Initial surgical options include goniotomy, trabeculotomy, and trabeculectomy. Goniotomy and trabeculotomy have been used in infantile cases with limited success. Trabeculectomy is the surgical procedure of choice for most patients with glaucoma associated with the Axenfeld Reiger syndrome. The success rate in older children has been about 75%, but with the same risks of late bleb, leak, and infection as seen in other children after trabeculectomy, especially if mitomycin C has been used. In infants and in cases refractory to medication and trabeculectomy, glaucoma drainage device surgery and cycloablation remain options for treatment. In a retrospective clinical series of 126 patients with Axenfeld Reiger syndrome attributable to mutations in PTX2 and FOXC7, Stringro and Cullex noted that glaucoma in only 18% of the patients with PTX2 or FOXC7 genetic defects responded to medical or surgical treatment, in bracket used solely or in combination, bracket complete.